Hello, and welcome to our listeners around the world. You're listening to JAMAevidence, our podcast series based on core issues in evidence-based medicine. Today, we're discussing test-negative study designs for evaluating vaccine effectiveness. I'm your host, Dr. Roger Lewis, Senior Statistical Editor for JAMA and editor of the JAMA Guide to Statistics and Methods series. I'm here with Professor Natalie Dean. Professor Dean, could you go ahead and tell our listeners a little bit about yourself?
Yeah, happy to, and happy to be here. So I'm Natalie Dean. I am an associate professor in the Department of Biostatistics and Bioinformatics at Emory's Rollins School of Public Health. And my specialty is in the design and evaluation of infectious disease studies. So I focus on vaccine studies, including observational and randomized trials.
Well, thank you so much for joining us today. So the article that you wrote for JAMA focused on a particular type of study design used to evaluate vaccine effectiveness, and particularly in the post-approval setting. So could you start by telling us what's different about the pre-approval evaluation of vaccines and the post-approval setting?
Absolutely. Yeah. So as vaccines move through that evaluation pipeline, typically that's going to culminate at a large phase 3 trial that can include thousands, even tens of thousands participants who are randomized to vaccine or some placebo. These are expensive studies, large studies, and they are the basis for regulatory approval. But then after regulatory approval, we continue to need to study these vaccines because the world continues to evolve. We think about flu, for example, and every year there's new strains. We think about updated doses like boosters. And we also want to know real world effectiveness. So once a product is licensed and out in use, how is it performing? And so that's where observational studies come in. While some post-licensure studies are randomized, the vast majority of our data comes from observational studies that either they enroll participants or they use databases and they estimate how well the vaccine's working in the real world.
So for this particular type of trial design, the test-negative study design, can you start by describing the structure of the design? How do we collect data and how do we think about the data on vaccine effectiveness?
Totally. So the test negative design is a study design particularly for vaccine evaluation. And as far as studies go, it's relatively new, but it started with flu vaccines. And it's got an interesting structure in that it's kind of like a case control study. But what you're doing is you're taking in people who have some sort of disease or symptoms. They go to a clinical site for testing. And the people who test positive become your test positive cases. So that's like a regular case control study. The distinction is that your controls are not just people out in the community like they would be in a typical case control study. They are people who actually were the people who had the same set of symptoms, met those testing criteria, but happened to test negative. And that's very convenient because they're sort of showing up into your system. And as long as you collect the right data on them, including their vaccination status and their covariates, you've got a built-in study that allows you to measure vaccine effectiveness. So these have become very popular over the last, 20 years.
So once you collect the number of people seeking testing who are test positive and test negative, how do you actually calculate the vaccine effectiveness from that?
It ends up looking a lot like a case control study. You've got your test positive cases, you have your test negative controls. And your test negative controls are really functioning as your source population. I mean, they're people, they're sick, but they're sick with something else. I mean, we assume they have some other illness which has nothing to do with that vaccine. So we can look at that population and see, okay, well, what fraction of them are vaccinated? And that becomes the comparison to the test positive cases. When we look at our test positive cases and we see, okay, what fraction of them are vaccinated? When the vaccine is working well, that's going to be a smaller fraction. So if the flu vaccine's working really well, most of your cases will be unvaccinated, right? So you use an odds ratio to compare those. And vaccine effectiveness is just 1 minus the adjusted odds ratio.
So what are the key assumptions underlying this study design?
One of the key assumptions for the test negative design that is really specific to the test negative design is the intervention you're studying, which most commonly is going to be a vaccine, has to only affect the cases. it can't also affect the controls. And that's what allows us to use the controls as this comparison group. When you think about a flu vaccine, right, that can prevent flu. It's not going to prevent all the other causes of respiratory illness. You can talk about the assumption about like nonspecific immunity or something, but generally we assume that the vaccine is only targeting that illness. And that means that then you can't use that design to study covariates that have an association with both the cases and the controls. The example we give is you think about people who are healthcare workers. People who are healthcare workers may be at elevated risk for flu, but they may also be at elevated risk for other respiratory pathogens. So just that design doesn't work there because you can't really isolate the effect of that risk factor. So that's why test negative designs, we use them for vaccines. Other example, a prominent example is with Wolbachia. That is the bacteria that can prevent mosquitoes from contracting and spreading dengue. And so like we feel good about the assumption that that Wolbachia is preventing dengue, but it's not preventing other causes of fever. So there's kind of a restricted set of settings where it works.
You mentioned specifically in your article that there are some types of bias that this design is particularly good for addressing. Can you go through those?
Yeah. So one of the biggest advantages is how the design focuses on people who have sought healthcare. It's restricting to a population that not only would seek healthcare if they had a fever or, had those symptoms, they did seek healthcare. And that's important because healthcare seeking behavior can definitely be a confounder in these types of studies. If the type of people who are very health conscious are the people who are getting vaccinated, they're also the people who are like the first to go to the doctor if they have an issue, then that creates this association that creates a bias. But here, what we're doing is we're saying we're only looking at the people who did go to the doctor. And by restricting to that subpopulation, we're reducing that risk of healthcare seeking bias. So that's nice, particularly for outcomes that are kind of whether someone actually gets tested kind of depends on like personal decision making and access and all these other things. When we think about like hospitalization and sort of more severe outcomes, maybe not so much, but for something like just having a few respiratory virus symptoms, that's where this design is particularly advantageous.
So you specifically mention the distinction between people with mild symptoms versus people with more severe symptoms. So how does that affect our interpretation of the results for determining the effectiveness against mild disease versus severe disease?
Yeah. So the way the test negative design works is that you have some outcome, right? And it's defined by some set of symptoms or some clinical presentation. And you're looking among those people with that clinical presentation who then are tested, who is testing positive and who is testing negative. And you can imagine applying that among people who are hospitalized. You can imagine applying it to people who are showing up to emergency departments or people who are going to urgent care. You can even go to the extreme, and sometimes we do see, like during COVID, we just had people who were getting tested just through like testing sites, and there weren't really strict symptom criteria. So there's a wide gamut, and those are naturally going to measure different things because typically vaccines work better against more severe illness. So it's important when you interpret the results that you know what outcome you're studying.
So what are the limitations of the test negative design?
A key limitation relates to the test itself. It's got to be a good performing test. And if it's not, then you're going to misclassify either your cases or your controls. And that's different from a case control study because if you have a case control study, okay, you have someone who really has flu, for example, and they happen to test negative, well, they just get dropped from the study. They're not included anymore in the analysis. But in a test negative study, they become now the controls. So there's like more chance for that type of misclassification. On the flip side, we also observed this thing where because of co-infections, like during the period when COVID was extremely prevalent, and you could imagine someone had a co-infection where their symptoms are due to some other thing, but they happen to also be infected with SARS-CoV-2, well, then that can also lead to another type of misclassification. So they can go both ways.
Professor Dean, in your article, you specifically explore an example of a published study in JAMA that used this design. Could you go ahead and describe that study and what the authors found?
Yeah, this was a really interesting study. It was a large study of drive-through testing sites across the country, across the US. And so you can imagine people come to these sites suspecting they might have COVID, and then they get a test and they report some very basic things like their symptoms at that time and their self-reported vaccination status and a few other demographic features. But, the long lines that we saw at some of those testing sites, because of this large network of sites, they were able to accumulate a lot of data very quickly. And then they can do an analysis of that data and look and see, okay, among the people who reported at least one COVID symptom, we can compare the test positive cases and the test negative controls. And what they were able to demonstrate was very high performance of the vaccine at that time for preventing symptomatic infection, particularly high during the Delta period and high but not as high during Omicron. And they were looking at 3 doses of the vaccine, so 2 of the main doses plus a booster compared to either unvaccinated, or they also did an analysis that looked at 3 doses of the vaccine, so the 2 main doses plus a booster versus just with 2 doses. So basically testing like the added value of the booster, and we're able to demonstrate additional protection that conferred.
And as you mentioned in the article, it really illustrated the efficiency of the design because it was such a short period of time that they were able to acquire, such a large data set.
Yeah, that's what's so appealing because you can think about it as this passive collection of testing data that you're leveraging. And as long as you have the right covariates that you need to do the adjustment, you can generate an estimate of vaccine effectiveness for JAMA.
What do you think the take-home message is for our audience?
I'd like your listeners to be familiar with the test negative design when they see it out in the wild. I mean, it's a design that we're only going to see more and more of over time because it is a convenient and effective way to monitor the real world effectiveness of vaccines after licensure. It can look at a lot of things like subgroup effects, waning effects, effects against different variants, effects against different outcomes, including rare outcomes. And because of its logistical convenience and how it addresses some of that bias due to healthcare seeking behavior, it's just a really helpful tool in our arsenal.
I'm Roger Lewis, and I've been speaking with Professor Natalie Dean about test-negative study designs for evaluating vaccine effectiveness. You can find a link to her article in this episode's description. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.